this is a real landmark for us. As you've heard, our 10-year anniversary since we began our work, and we started with working on eliminating healthcare-acquired infections, and have expanded over the years to work on other forms of medical harm to try to eliminate that harm. We know, and as you've heard some today, not a lot, but we do know that progress is being made and that lives are being saved. But we also know that we have a long way to go. We can't become complacent. And what we hear, especially in the arena of healthcare-acquired infections, there's a lot of activity, and a lot of people are saying, we're doing better, we're doing great, and we can't become complacent, and we can't let the policymakers believe or claim that we have this under control, because we do not. We are making some progress, but the sheer scope of this problem demands urgent action, and that is clearly not happening. Just think of a problem that kills more than 400,000 people a year, and that should sound off alarms. But for some reason, this problem has not raised those kinds of alarms and is not raised to the level of urgency. And that is an issue that we often talk about in our work here, is the urgency of taking action, and there isn't that present. We have the knowledge and research about what needs to be done to prevent medical harm. We have the momentum, but sometimes I wonder if it's strong enough to sustain it. And when I come to events like this, it makes me feel stronger, and I know that we're getting stronger every day, but we really have a lot of work to do. One of the issues is there's not resources to this problem that reflect the urgency that is needed and reflect the scope of the problem, not private resources. Hospitals don't put in what they need to be putting in, and not public resources. Every day, hospitals make decisions about what to do with their money. And often, too often, they fail to put it towards things that make a difference in keeping patients safe, like more nurses, more infection control, more education. So one of the things I wanted to do today, just because it is our anniversary, is to take you back to 2003 when we initiated our campaign to get public reporting of hospital-acquired infections. And I wanted to tell you a quick story about how consumers move this issue onto the national radar. It is an empowering story, and you've heard some of it today. I'll try not to repeat myself, but it's something that most people, even people who work in the professional arena, who've been around, don't realize that this all started with consumer actions. 10 years ago, when we started, experts and doctors accepted infections as inevitable. As long as their performance was average, they thought they were okay. But average hurt a lot of people. The prevailing belief was that a small percentage of infections were preventable. But we know now that preventability changes over time. It is not a static issue. We learn new things, we learn how to prevent. And today, many people are talking about achieving zero infections, and even more, say 75% of infections are preventable. And you saw John's numbers around that number. So we had some statistics back then in 2003, but they were not widely known to the public. And what we knew about infections was based on a small sample of hospitals that voluntarily submitted their information to the CDC, 315 of them to be exact. And they did it for about 30 years, and all the estimates were based on what those hospitals told the CDC. And when we started, we felt very strongly that hospitals knew their infection rates, and they were keeping it secret. And we felt that the public had a right to know this secret. What we quickly found out was that hospitals had no idea how many people they were infecting. And I would venture to say most hospitals today have no idea how many people they are infecting. Most of the time, the symptoms of infections reveal themselves after the patient has left the hospital. And there isn't a good tracking system of that, or a good feedback system. So what we have is a tip of the iceberg. We don't really know throughout the hospital how many people are being infected. Back then, it was almost a don't ask, don't tell mentality. They didn't want to know. They didn't want to ask. They didn't want to look. They just knew that they couldn't do anything about it, and it really wasn't that many people anyway. And the problem is those numbers, like the numbers John showed you, the 34 million people who go into the hospital. When you do small percentages of those, it's a lot of people. With infections, it was 2 million people. 2 million people got infected every single year. In 2004, what we did was we drafted a model bill and took that bill on the road. And it's an interesting little note that we modeled our model after an Illinois bill that was passed that year, or I think it might have even been the year before that it was passed, and the sponsor was a senator named Barack Obama. And we thought, well, this was the first law that actually was passed that showed, that required hospitals, mandated them to report their infections. And so we took that model, we tweaked it a bit and improved on it, and took it on the road. One of the things that somebody mentioned earlier today was how long it takes to bring about change. The Illinois law that we thought was so great back then in 2003, it took 7 years for them to get a report to the public on infections. When they did it, it was a good report, but it took them a very long time. So when we took this model bill out, we engaged tens of thousands of consumers who asked their state legislators to file the bill, and many of them did. And many of those legislators were, like most people in the public, they thought, well, somebody's watching this, somebody's keeping track of these infections, nobody's ignoring this. If they hurt somebody, then it gets reported and there is action that happens. But they were shocked to find that that was not the case, that there really wasn't anyone tracking these infections. There wasn't anyone keeping up with what was happening. And the legislators that stood up on this really faced a lot of opposition, and you've heard a lot about that today. The medical industry is very powerful at every level, including state levels. In almost every state we went to, the advocates there said, oh, you don't understand. In this state, the Hospital Association is really, really powerful. And they told us that in every single state. And we knew that they were powerful. But these legislators and the consumers that we engaged stood up to those opponents and naysayers. They didn't think it could be done, and there wasn't a system for it, and there were all kinds of reasons why they shouldn't have done it. When we first, in the 2005 legislative session, we took this, asked people to file bills. We were astounded that 30 states filed bills immediately. They didn't all pass the bills that year, very few of them did, but 30 states, there was an interest to file the bill and to get this kind of information. It was a real wake-up call for us to know how this resonated. Another thing that happened around that time was the CDC has an infection prevention committee that are all the experts nationally that set guidelines for infection prevention. And they had a big debate as to whether they should provide guidance to these states that are talking about mandating public reporting. And the debate was, we need to provide guidance, and the other side of the debate, which was the majority of the group, said, we should just tell them don't do it, it's a bad idea. They should just not do it. I attended one of the meetings and I stood up and I said, it would be really helpful if you would give some guidance, because otherwise I'm doing it. And I don't know as much as you do, but I'm going to keep doing it. And if you gave us guidance, then that would help along. And finally, in 2005, they did sort of add their scientific guidance about what should be reported. And as a consequence, many of the states followed that guidance. We asked people to share their stories, and we've talked a lot about how people shared their stories and became really strong grassroots advocates and helped us pass these bills. They testified and lobbied, and they basically were, there were at the beginning, there were just two of us, but then there were three, and Michael, who does our media work, which is a big help, but we were able to get these people interviewed by the media, and that made a big difference in every state. They were on the ground, so they were reporting, and some of you are those people I'm talking about, telling us day by day what was happening in your state. The reporters that we met along the way were instrumental in putting a human face on the statistics around infections. And then once these laws were passed, advocates, many who are in this room, served on committees and helped to implement these laws, which was a really, as has been mentioned before today, is an essential part of making this happen. You can't just pass a law and walk away. You have to keep at it to make sure it's done right. And they continually raised the issues and confronted the powers that be that these infections could be prevented. We were scrappy, and we were faced big money, but we were powerful because we weren't afraid to speak up. And as you've heard, more than 30 states actually passed mandated public reporting of infections. And in 2011, the federal government created a program that it didn't require all the rest of the hospitals in the country to report infections, but it made it financially untenable to them to not report it. They would have their Medicare payments cut across the board by 2%, and that was a significant amount of money that brought all the other hospitals in. And those reports are now available on hospitalcompare.gov. It has its flaws, as we heard from our first panelist, that it's not a perfect system, but we do need to have that data available so that translators like the journalists that were here earlier can actually take it and make it into meaningful information. Public transparency was just part of what made this happen. The other things that happened was there were groups of experts that actually trained hospitals, taught them what they needed to do to prevent infections and errors. We were a catalyst with the mandate, and once that mandate was in place, hospitals were motivated, more motivated, to go to these experts and say, what can I do? What can I do to reduce infections? And so that was a big part of how this issue sort of rose to national attention. There were early innovators at hospitals, early hospital innovators who sort of got out there and said, we tried this. They would get up in conferences. It was really kind of interesting. They would get up in conferences and give a speech about how they tried this best practice. They actually put it in place for 6 months, and they hadn't had a single infection. And they were almost evangelical. This study that said it would prevent infections actually worked. And so that really prompted a lot of other people to try these best practices. And there were people like the Institute of Healthcare Improvement, organizations like that, and Peter Pronovost, who took his checklist around the country. And now there are more programs under the Partnership for Patient program of the federal government that actually have funneled money around to help train hospitals on what to do. And the other thing that happened is that an emerging number of federal policies came out that connected financial incentives to doing better or to be safer, or disincentives, I should say, to harming patients. And there were a number of programs that either wouldn't pay the hospitals if they hurt people, they would have to eat the cost, or and these programs are now being rolled out for the first time in the last year or so, where they take the bottom quartile of performers and they cut their Medicare payments across the board by a certain percent. So it always raises the people at the bottom to come up. So all those things together really made this energy and happen. And Our big challenge is to figure out how to sustain that, not just with infections, but we need to do the same thing with medical errors. I mean, that is a huge part of this problem. We don't have any national reporting system. Most states don't have reporting systems for medical errors. We just don't have a handle on where those are happening. And if you don't look for it, if the hospitals are not looking for it, they're never going to stop it. Awareness is that first step towards ending it, and it's so important. So each time we've taken on a new issue, we've gotten more people engaged, and a lot of the people here came in on other issues. We started working on physician accountability, and Pete Eisler brought it up, and I'm going to say it again. I think the answer, while we are doing some monitoring of medical boards and trying to make them accountable, those are state agencies, and I'm not sure that we have enough people that can make every medical board do what they need to be doing to regulate doctors and to really weed out the very small percentage of doctors that are a problem. There's a big reluctance to act. So we like to approach it by giving people information and making sure that hospitals make that information available. Patty Skolnick, who was here a minute ago, I don't know where she is, she's still here. She created a profile bill in Colorado and has expanded it beyond physicians to all health professionals. And many states have profiles, but they don't have everything we'd like to see. Like we would like to see their medical malpractice records, any disciplinary actions in other states or by hospitals where they work. That kind of information is important for people to be able to see. But the real mother lode is the National Practitioner Data Bank. This is where problem doctors are reported. So when there's a malpractice settlement or Medicare fraud or disciplinary action by a board, that goes to the National Practitioner Data Bank. It is paid for by our money, but we can't see it. And because doctors today are very mobile, they cross state lines, they have multiple licenses in different states, that is really the only answer for us as consumers to know, is this doctor practicing in Texas, does he or she have a clear record in all the other states where they practiced? So that will take a federal law change. The AMA will fight that tooth and nail, but I think that is something that needs to happen. Today we can look at the data bank information, but the doctors' names are de-identified. They're just identified by numbers, and you have to sign saying you'll not use any of this information to identify a doctor. So it's very restricted in the way you can use it. And then we expanded last year, in 2012, we expanded our work to include medical device safety, and you've heard some of that. And I'm not going to go into what we did last year to try to strengthen it, but there's this routine review of the user fees that are charged by two device companies and drug companies that help to fund the FDA. And so every 5 years, that bill comes back up again to be reauthorized. And so we didn't do very well last year. It was our first year out there, and we didn't make much progress, but we did make some noise, and that's important. And from then until the next review, we're going to be building an army of advocates so that when it comes up the next time, we're going to really have a strong voice to counter the medical device industry. And lastly, what we started doing this year, which is going to be really fun, and we would love to engage any and all of you in this campaign to try to get the makers of hip and knee implants to warranty their products for 20 years. What we want is for them to tell patients up front, here's how long this is going to last. Here's how long we will back it up. And if it doesn't last that long, we will repair it, replace it, parts and labor. We're only talking about the product failing, but there are some organizations around the country, and Washington State is one of them, that are looking at creating a package of warranty, including the doctor's care and the hospital care, to warranty against infections or medical errors, as well as the product. So our hope is to work in Washington and get a comprehensive package of warranty for patients, and maybe then move that out into other parts of the country. In the meantime, for the rest of the country, we're going to be working to put pressure on these medical device companies to warranty their products and to back them up. And we don't have to go to any legislators or elected officials. This is a marketplace campaign where we're going to put pressure on the companies to do right by their patients. And I think it's going to be, it's an issue that's really resonated with the public. When we put out our request for stories about tell us your hip and knee story to our 1 million people that we write to that have signed up for Consumers Union's work, we got almost 3,000 stories. There are a lot of people out there who have hips and knees. Most of those people are happy with their hip and knee implants. 25% had problems. But the ones that were happy, they wanted to have a warranty. They wish they had known more about their implant. So there's a lot of education there to be done also. So our goal when we started 10 years ago was to create a consumer movement that would change the marketplace, and we have one. We always need more people to question why information is not available, why regulators don't use the power that they have to keep in line the real problem makers in healthcare, and to question, as you heard on this last panel, to really question the recommendations of their healthcare providers. Ask for that second opinion, ask for more information about what they're wanting to do with you. And so I hope that you will go to our website, safepatientproject.org, and see what we're doing and keep up with what we're doing and keep in touch with us and join us in some of the work that we're doing. I thank you so much for coming today, and I hope that you'll help us spread this message. As we leave today, some of us are going to do a direct action at St. Luke's Roosevelt's, which is right nearby here, to call attention to the need to end medical harm. We're not there to be confrontive with the hospital or anything, but we want to tell people of New York City that not only is St. Luke's having issues with surgery safety, which was rated by Consumer Reports, but most of the other hospitals in New York City had poor ratings on their safe surgery. And we really want the people of New York to know this and start to ask questions of their hospitals. Why aren't you doing better? You can do better. Let's do better. And if we can help you do better, we'll do that. But we want safer care. So please join us if you'd like.
What is the action consist of?
We're going to walk down there, and we have signs, and we're going to pass out things on to people on the street. Information to people. Yeah. So I don't think that there are any questions, and Daniela's got some signs over there. We will, it'll be short, probably about an hour, and you're welcome to join us. And most of all, I thank all of you for coming and spending your day with us, and I hope that you learned a lot. I know I did, and we're very happy that you joined us. Thank you so much.
Next to everybody with the sign, somebody should be next to them handing things out.
Okay.
All right, you got that?
You got an assistant?
I got an assistant. All right, so I'm gonna hand things out.
Because our signs are complimentary. They complement your colors.
Okay. We both have a sign. Somebody can. Yes. Everybody has a sign. We'll hand these things out.
Oh, really?
Blue items.
Oh, I think he just put a stand here, put it in the group.
There's like,
Oh.
We're gonna not be on the corner, we need to push all the way around that way and this way.
My dad on the 80s birthday was killed by medication error.
That way.
Yeah. Did you get one? Okay, thank you. Is this a good one? You take a free hand sanitizer. Nursing student, did you see that?
no, I
It's
didn't
the
know.
College of Nursing. We need good nurses.
I told her I was rating the hospitals, and St. Luke's doesn't do that well, huh, when she looks.
I guess not. Yeah. But you know what? We can always do better. That's the idea. It's just, even if it's good, let's do better.
What's all this about?
This is about patient safety.
They're not trying hard enough? Does commercialization play a role?
Yeah, sure does.
So the ways of the business world don't quite point to the ways it ought to happen, huh?
Well, you know what this is all about? Public awareness and patient safety. And we're here to basically make sure that people are brought aware of the errors that are happening in the medical industry, and we want to make sure that they get the right information that they need to make right choices. As a group, we're trying to make a difference.
Talk about what we're.
Would you like the flyer?
And it has the New York City, it's got the New York City hospital ratings on the back for surgery.